Welcome back, everyone. In an obligatory change to the running order, I'm sorry to say that Professor Emanuel is unable to join us today and discuss gastrointestinal problems and Marfan syndrome. So we instead have a recording of a recent GI webinar we held that was hosted by Professor Quasim Aziz. Just to briefly introduce Quasim Aziz, Professor Aziz, he's a renowned professor of neurogastroenterology, meaning the functional GI disorders such as IBS or IBD, and he's the director of the renowned Wingate Institute at Queen Mary's University of London. He's been prolifically published in journals such as The Lancet, and he recently demonstrated the association between joint hypermobility disorders such as Ehlers-Danios and gastrointestinal symptoms in functional GI disorders, including IBS. This is an active clinical and research interest for him. In this 20-minute recording today, he will focus on GI symptoms in Marfan and the overlap between Ehlers-Danlos and Marfan syndrome.
This is a slide, which is a slide of histology, which shows what is there in the makeup of the tissues of the gut. And what you're looking at is a cross-section of two muscles. You have the gut has two muscle layers. There is an inner circular muscle layer, which you see at the bottom left over here. It is labeled circular muscle layer, and you can probably see my cursor moving there. And then there is an outer longitudinal muscle layer. And what you see is that particularly in this longitudinal muscle layers are these connective tissue scaffolds coming down. So the muscles have quite a lot of connective tissue, which strengthen the muscles. But between these two muscles, there is a network of nerves known as the myenteric plexus. This is a very extensive nervous system which is present in the gut. It is described as a little brain of the body. And the nerves in this nervous plexus are as many, if not more, than the nerves in the spinal cord. So the gut is a very nervy organ. And what you see is that there is a lot of connective tissue, collagen and elastin fibrils in this layer of the nervous system. So the nervous system is supported by these collagen fibers and elastin fibers. So now you can imagine that whenever there is a problem with the connective tissue within the gut, there can be problems in the tone and strength of the muscles because of these connective tissue scaffolds, but there can also be problems with the nervous system within the gastrointestinal tract or the gut, so to speak. So this is the sort of understanding currently as to why these problems occur if there is in the gut, if there is a problem with connective tissue. The gastrointestinal problems that are described, as I've said, often overlooked, but when they occur can be quite significant, are conditions like hiatus hernia, and I'll describe that, what that is. Gastroesophageal reflux disease is when you experience a lot of acid reflux and regurgitation, which is food or fluid repeating on itself and coming up into your gullet or food pipe. Diverticulosis is when small pouches can form in the colon, and that they can sometimes get infected. Constipation with the sluggish bowel movements are common, and there are a few others that we will talk about. First, we will talk about what these functional gastrointestinal disorders are. So by definition, these are disorders of the gut, which are conditions characterized by recurrent gastrointestinal symptoms or chronic gastrointestinal symptoms. And one of the key characteristics is that the gut does not show any structural or biochemical abnormality that can explain the symptoms. So there's rather unexplained symptoms, but there is an abnormal function of the gut. So the gut may be more sensitive, or the gut may be moving too fast, or the gut may be too slow, and that can cause the symptoms. So it's not a problem with the structure of the gut. There's no inflammation, there's no blockage, and all the scans and the endoscopies always come back as normal, but they have a lot of symptoms because the gut nerves and muscles don't function as well as they should do. The common problems that you may have heard about are irritable bowel syndrome, commonly described as IBS. Functional dyspepsia means indigestion when there is no ulcer present, no other cause of indigestion. Functional constipation means when there's constipation, but there is no underlying cause that can be identified. And functional diarrhea, similarly, is diarrhea in the absence of any other underlying cause. These conditions are quite common up to, if you look at the general population, anywhere from about 2% to about 15% of the population can suffer from one of these problems, one of these conditions, and they can significantly affect the quality of life of our patients. And diagnosis often involves exclusion of other conditions that may cause similar symptoms. And there are some international criteria. The current one that is commonly used is the Rome criteria that is used to diagnose these functional gastrointestinal disorders. Symptoms vary depending on the disorder, but commonly include pain as a common symptom, bloating, altered bowel habits, and discomfort are common problems. And these symptoms can often be triggered by a variety of environmental factors like stress, like diet, changes in hormonal function. For instance, young ladies, they tend to get more symptoms at the time of their menstrual period. And there are alterations in the way in which the gut and the brain interact, something called as gut-brain axis or gut-brain interaction. That has been found to be problematic in these patients. Management is usually through lifestyle modifications, dietary changes, stress management if stress is present. There are medicines to alleviate symptoms, particularly antispasmodics. And what their authors are looking at here is what are the types of these gut-related problems, functional gut problems that they are experiencing. And if you look at the first condition here called IBS, irritable bowel syndrome, and we look at the prevalence so in brackets are the percentages. So 57.8% of all the EDS patients complained of irritable bowel syndrome. This was less in Marfan syndrome, was 27%. And this p-value is whether this is statistically significant, and anything less than 0.05 is statistically significant, and therefore 0.001 is very highly statistically significant, okay? So in medical research, we don't look at just the percentage. It looks different, then it's different. We have to check whether using statistical methods, we can actually see that they are truly different from one another. So yes, they are different. So the prevalence of IBS, whether it be IBC means constipation, IBSD means diarrhea predominant, both of these are more common in EDS than in Marfan's. But this 27% is greater than the population prevalence, maximum of around 15%. Dyspepsia means indigestion. So overall, 55% of EDS patients had indigestion, 25%, half of the EDS population had of Marfan syndrome had indigestion. The type of indigestion, there are two types. Postprandial means post-meal distress, that after meals, they feel very distressed. They get a lot of discomfort, they get bloated in the abdomen, they can get indigestion of heartburn, etc. About 50% of EDS patients and 21% of Marfan syndrome patients. And this epigastric pain, which means a lot of pain that occurs after meals, was not very common in either EDS or Marfan. And this is our clinical experience in EDS, at least, that we see mostly this postprandial distress. Other problems like constipation, diarrhea were less common. Heartburn is common, 33 and 16%. Then dysphagia, which is difficulty with swallowing, 28% in EDS and about 18% in Marfan syndrome. Cyclical vomiting, which is episodes of vomiting that can occur at various intervals. So you have absolutely fine, then you get a period of vomiting for 1 or 2 days or more, and then you're absolutely fine again. This seems to be linked with migraines, and that was 20% in EDS and about 10% in Marfan's. And a few other conditions. Aerophagia is swallowing, is more common in EDS, 24.5, 24.7 and 12.3 in Marfan's. So anything which is higher in Ehlers-Danios also seems to be higher, although less so in Marfan syndrome. And idiopathic nausea means unexplained nausea and so on. So then the last column is GI limitation on quality of life. Due to gut symptoms, what is a limitation on quality of life? So 19% of EDS patients said that because of the tummy symptoms, there was an effect on the quality of life, and 10.3% said that in the Marfan's group as well. Then they compared, there's a type of Ehlers-Danios called hypermobility type, HT here. This is the most common form of Ehlers-Danios syndrome that we see, where the gene is not known, whereas in all the other subtypes of Ehlers-Danios syndrome, the gene is known. And they found there was actually no difference in any of these gut-related problems in those with hypomobile type and all the others put together. There was no difference in the presence of symptoms. And then they looked at the pelvic floor problems that occur in patients with Ehlers-Danios syndrome and Marfan syndrome. And what they found was hemorrhoids were very common in EDS, and they were also quite common in Marfan syndrome, although the difference was still statistically significant, so more common definitely in EDS. Anal fissure, which is a break in the anal sphincter, which can be very painful at the time of notification, was 47.7% in EDS and 20.5% in Marfan's. Rectal prolapse, where the rectum can prolapse out from the rectum as they strain to evacuate their bowels. The rectum can come down and sometimes pop out of the anus, was about 16%, 16.5% for EDS and 6% in Marfan syndrome. And that's age-related, more common in those in less than 50 years old. Fecal incontinence, almost 19% in EDS and 11%. But incomplete evacuation, I think, is worth looking at, because 83% in EDS patient and 65, almost 66% in Marfan syndrome felt that when they go and try and evacuate and open their bowels, they do not feel that they've emptied themselves properly. And so functional defecatory disorders where they feel that there is a problem with their bowel movements was quite common in EDS patients, 60% and 34.5%. Proctalgia, chronic proctalgia is chronic pain in the rectum, was 14 and 5.3%. Proctalgia fugax is intermittent severe pain. That is actually quite common, 24 and 14. But urinary incontinence of urine, is quite common in EDS patients, 60% versus 38.8%. And incomplete emptying of the urine, incomplete urinary voiding is also very common, 75 and 50%. And then about 13.5% had a hysterectomy for bleeding, just over 8% in EDS patients. A little bit of uterine prolapse in EDS and Marfan syndrome patients. Quite a lot of endometriosis in EDS, less so in Marfan's, about 10%. And rectocele is a small pouch that can form the rectum, about 14% and 3.7% in those with Marfan. So pelvic floor problems are also some of these quite common in patients with Marfan syndrome. So normally, this is the esophagus is the food pipe that brings the food from the mouth down the food pipe into the stomach, which is just below this big muscle which separates the chest cavity from the tummy cavity called the diaphragm. Okay, so the stomach is below the diaphragm, esophagus is above the diaphragm. In hiatus hernia, there's a subtype called sliding hiatus hernia. The stomach slides through the hiatus, or the hole in the diaphragm, up into the chest cavity. So stomach is moved up in the chest cavity through that hole, the hiatus. This is called a sliding hiatus hernia. And then we have the paraesophageal hiatus hernia, where a bit of the stomach, the upper part of the stomach, slides up, not the whole of the stomach, but just one part of the upper part of the stomach slides up on the side of the esophagus, and that is described as a paraesophageal hernia. So this seemed to be more common, or at least a couple of, in the cohort of 40 patients, 2 patients had Marfan's syndrome. What is the general approach? Just reassurance and knowing that there is a problem, an explanation why multiple symptoms, not just muscle and joint problems, but cardiac problems and gut problems can be associated with connective tissue disorders, and having a multidisciplinary approach with dietitians, pain managers, special psychologists, and if there is POTS and other urogynecological problems, then we have other colleagues who can try and address those. It's always good to make sure that you exclude other organic causes like inflammatory bowel disease, celiac disease, autoimmune connective tissue disorders. And then if those are excluded, then we have a lot of tests to understand function of the gut. We can do tests to see whether your stomach emptying is normal or delayed. We have breath tests like hydrogen and methane breath tests to say whether you have unhealthy bacteria in the gut. We can do tests on colonic transit. We can look at your pelvic floor with anorectal manometry and evacuation photograms, and so on. Lifestyle and dietary management is often used and helpful. And then food can be a trigger for symptoms, and we then consider whether low FODMAP diet and the recently described low histamine diet, whether they can be helpful. But by and large, it's important to take a good dietary history, and keeping a food diary can be helpful, and then see what are the specific triggers and avoid those triggers rather than very detailed and extensive dietary restrictions. Acid reflux is a very common problem, and can be investigated through an endoscopy, a camera test where you can look to see whether there is any evidence of inflammation in the esophagus. Barrett's esophagus means that there is a change in the lining of the gut, which needs to be kept under surveillance because there's a small risk of cancer, but this is quite an uncommon condition. All of these things can be identified on an endoscopy. And if the endoscopy doesn't show any problem, but there are still symptoms of reflux, we can do a further test known as esophageal manometry and pH test. It's a combined test where we look at motility of the esophagus and acid reflux. And it's very useful when considering surgical intervention, because you may have typical symptoms of reflux, but actually do not find any reflux when we do a more objective test where we measure acid through a pH sensor by placing that sensor in your esophagus through a tube. And we look at a 24-hour profile, and we actually don't find much evidence of reflux. And there is very poor correlation between symptoms and reflux. So for that person, anti-reflux surgery is not ideal. And if your esophagus is very weak, then also a surgery which will tighten the lower end of the esophagus, so it will cause difficulty with swallowing. So these tests can be, and there is also this wireless pH. If you can't tolerate a tube, then there's a capsule that can be attached on an endoscopy, through an endoscopy to the lower esophagus, and that can measure how much acid is coming up over a longer period of 48 to 78 hours. Management of reflux is lifestyle modifications, elevate the head end of the bed because quite often the symptoms are at night, avoid lying down for 2 or 3 hours after eating, maintain a healthy weight because it's been shown that people who are overweight tend to get more reflux, avoid trigger foods like spicy foods, fatty foods, acidic foods, eat smaller, more frequent meals, limit alcohol and caffeine intake, quit smoking. Smoking seems to make reflux worse. Then there are medicines called proton pump inhibitors. These are medicines that shut down a pump called the proton pump, which reduces acid secretion or even shuts down acid secretion in the stomach. Before considering surgery, you need to try this out to see if that helps with the reflux symptoms. Other medicines like histamine receptor antagonists. Previously, we used to have ranitidine, which is now banned, but there's another one called famotidine or cimetidine that can be used. And antacids like Gaviscon can be quite helpful for individual episodes of heartburn. As I've said, that we, making some dietary changes, etc., can also be helpful. In severe cases where medical treatment has failed, there are some surgical interventions like fundoplication, which is wrapping up the top of the stomach around the lower esophagus to prevent acid. You just tighten up the valve at the lower end of the esophagus, or the Lynx device, which is the magnetic ring, which was the history that was sent to me to strengthen the lower esophageal sphincter. Constipation management, keep the stool soft, lots of foods like prunes and other fruits and vegetables. Movicol, which is a stool softener. Senokot and Dulcolax are stimulant laxatives. And if these simple treatments fail, then prokinetics, these are medicines that stimulate the nerves and muscles of the bowel. And another one called linaclotide or Linzess is a similar medicine that can be used in the management of constipation. And if there's a lot of evacuatory difficulty, then glycerine or bicipodal suppositories can be used. And there are treatments like biofeedback, which can be used to help strengthen the pelvic floor. But sometimes surgery is required. Sometimes we use probiotics. There are various probiotics that are available, but these are the ones that I've listed here that have some evidence that they can be helpful. We use them in patients with irritable bowel syndrome and those who have unhealthy bacteria known as SIBO, small intestinal bacterial overgrowth. And as I've mentioned, low FODMAP diet, etc., can be helpful in some patients. For irritable bowel syndrome, we need a detailed history to look at what triggers symptoms, the duration of symptoms, physical examination to rule out other conditions. There is this international criteria that can be used to positively diagnose, some basic stool studies to rule out any other infections, to rule out blood in the stool, etc. And then other blood tests to rule out celiac disease, thyroid disorders, etc., to make sure we're not missing anything. And endoscopy and imaging can be used in those who have alarm symptoms like weight loss, etc. And then again, lifestyle modification with dietary adjustment, exercise, stress management, medications such as antispasmodics, antidiarrheal agents, laxatives, probiotics can be helpful. Psychological therapies, CBT, gut-directed hypnotherapy, patient education, and there are various other pharmacological treatments that can be used. So just to summarize, gastrointestinal problems are common in Marfan syndrome. Regular screening and early diagnosis are essential. Treatment should be tailored to individual needs. It's important to have a multidisciplinary healthcare team, but I would mainly say that there's a room for a lot of research in and around Marfan's syndrome and gastrointestinal problems. And there's a lot of research occurring in EDS and gastrointestinal problems, but I think Marfan's and gastrointestinal problems should also be researched more. With that, thank you very much.
Thank you, Professor Aziz.